We have a really interesting agenda today, and I'm very grateful to all of our speakers and chairs for giving up their time to share their expertise. I'd just like to thank the Executive Committee really for pulling together the agenda, and I hope you really enjoy the day. I'd also like to thank our sponsors for being so generous as always. Could I ask anybody with questions to write them in the chat bar, please, and the chairs will direct those questions to the speakers. We've tried to build in lots of time today for discussion, so please feel free to put anything in the sidebar and we'll make sure your points are covered. So I'd just like to again welcome everybody and hand you over to Dr. Andy Yeoman and Di Samuels, who are going to chair the first session. Thank you very much.
Thanks, Hayley, and good morning, everyone. And so the first session this morning is dedicated to matters of the liver, particularly around liver cancer and end-stage liver disease. The first speaker is Dr. Tom Pembroke, who's a consultant hepatologist at the University Hospital of Wales and a senior clinical lecturer at Cardiff University. Tom chairs the South Wales HCC MDT, and his research interests include the epidemiology of liver disease in Wales through the development of the liver disease registry, where Tom has been absolutely instrumental in that work. And he's also interested in developing immune biomarkers in decompensated liver disease. Tom's done really sterling work in terms of his leadership of the HCC MDT over the last year or two, and so he's extremely well placed to talk to us about hepatocellular carcinoma management of local services. So, Tom.
Morning. Thank you very much for asking me to speak on HCC today. My name is Tom Pembroke. I'm one of the hepatologists at UHW. Let's start by discussing a case. This gentleman's currently 70 years old. In 2015, he was diagnosed on biopsy with NASH cirrhosis. He had diabetes, hypertension, and he was overweight at that time. He was enrolled on a surveillance program and underwent regular ultrasound and AFP monitoring with Ian Rees and nursing staff in Llanelli. In November 2019, he had a possible right-sided lesion on ultrasound with a normal AFP. He had a CT scan which failed to identify the lesion, but cirrhosis and signs of portal hypertension were confirmed. The local radiologists weren't happy with this scan and suggested a further MRI scan which confirmed two HCCs, segment 5 and 6, and this is shown at the lower centre of the screen. At this time, this gentleman had well-compensated liver disease. He was Child-Pugh A, and he was discussed in Cardiff MDT. At that time, the plan was to refer to Birmingham for consideration of transplant and to give TACE as a bridging therapy to hold his HCC once that transplant could take place. He was referred, but he was found quite early on to have left ventricular dysfunction, and for this reason he was not a candidate for transplantation. He was then unfortunately dealt a double blow because the COVID pandemic started to take hold and his TACE was put on hold for several months until May, when he had repeat imaging. And at that time we rediscussed and it was planned to proceed with TACE. In September in the summer he had his TACE, and in September he had a good response to segment 5 lesion. Segment 6 lesion had enlarged slightly. It felt that there was probably room to give further TACE, and this was delivered in November. Unfortunately, in January, he had a further mixed response to his TACE. There was some evidence of residual disease in the segment 5 site, and segment 6 had progressed further. The smaller lesion, the plan was for ablation. The larger lesion, we planned to give SABR radiotherapy, which requires fiducial marker placement, and then he had 5 fractions on alternate days, totaling 50 gray. And following this, in June, he had microwave ablation of the smaller lesion. We've just discussed him in the last week or so in the MDT, and he has had a satisfactory post-ablation effect to segment 5. Unfortunately, the segment 6 lesion has continued to progress, and concerningly, there are multiple small lesions which are suspicious but not diagnostic of HCC. But the major issue is that his bilirubin is now 70, and he's currently not a candidate for treatment. But if he were to recompensate, then we would consider systemic therapy as the next line of treatment for this gentleman. So HCC in Wales is increasingly a problem, and this is really related to the fact that liver disease in general is a decreasing problem in Wales. If you look at the figure on the top left, what you see is the number of hospital-related diagnoses over the last 20 years in Wales, and you see a threefold increase, which has really been driven by fatty liver disease, shown in the red. Fatty liver disease has had a tenfold increase in incidence in this time frame. In line with this, we see a doubling in diagnoses of cirrhosis, portal hypertension, decompensation, and liver cancers. And shown on the right of the screen, you see a marked increase in the number of referrals year on year to the HCC MDT until 2020, when we saw a significant drop-off related to the pandemic. What can we do about all of this? Well, the one thing we can try and do as we see more and more increase of incidence is to try and pick up the individuals who are at risk of liver disease and cirrhosis and try and screen them from the complications. And here we're really talking about ultrasound with or without AFP monitoring. Personally, I monitor AFP because if there's a change in the trajectory of the AFP, that nudges me to consider cross-sectional imaging, even if it doesn't reach a particular cutoff. And when we're thinking about screening, we are obviously thinking about the risk of the disease in question and the benefit of picking it up earlier. And there are really two groups and two risk profiles that we're trying to pick up here. The first are those with the lower risk but the greatest additional benefit. These are individuals with a risk of about 0.2% a year, but would be suitable for surgery. This is the non-cirrhotic viral hepatitis group, particular subgroups of hepatitis B, hepatitis C, and HIV and viral hepatitis co-infected individuals should be screened. And secondly, it's those individuals with established cirrhosis where the risk is greater than 2% a year, so that's all cirrhotics, who would benefit from identifying lesions that can be treated. Unfortunately, in advanced disease and in frail people, the treatment options are limited to best supportive care, and for this reason we would only recommend screening individuals with Child-Pugh A and B cirrhosis or Child-Pugh C on the transplant waiting list, because these are the groups that we can impinge upon if we find a lesion and offer treatment. Mentioned briefly the diagnosis of HCC on imaging. We are able to diagnose HCC on imaging alone, and this is for two reasons. One is that in a cirrhotic liver, it's a difficult environment for metastases to seed, therefore cancers are more likely to be HCC. Secondly, the liver has dual blood supply from portal vein and hepatic arteries, and hepatomas are only fed by the hepatic artery. So for this reason, you can pick up lesions on dynamic imaging. An liver lesion over 2 centimeters in a cirrhotic liver with an AFP of greater than 200 is also diagnostic. The question is here, which is better? The relatively straightforward CT, which we all have good access to, or MR, for which we certainly have a significant weight in Cardiff, related to the huge pressures on our diagnostic radiology colleagues. Well, MR has a greater sensitivity than CT scan, but with a similar specificity. And for this reason, most of the cross-sectional body radiologists that I discuss with would much prefer MRIs to try and diagnose HCC. I think the caveat here is that if you have large volume ascites. There is a degradation, I'm told, in the image quality, and for that reason CT is probably more appropriate. Where if you have these individuals who've got very advanced disease, which you're unlikely to treat in the immediate time unless they recompensate, then my own feeling is triple phase CT is your best option. Try and treat the liver disease, and if you're concerned that there may be an underlying lesion, once they've recompensated, go on and do the MRI at a later time point. So one of the things that we've developed over the last few years is an optimal cancer pathway along with all the other tumour sites. And this does two things, I suppose. One is it gives us aspirational targets to try and benchmark ourselves to, and it also provides a framework for what to do if you have an individual who has a malignant looking liver mass and you're not sure whether it's an HCC or not, and the best way to get that individual through to the MDT with an outcome that you can action. So for me, these individuals fall into two groups. One is the screening cohort, where you're obviously looking for this, and then as soon as you get that answer from an ultrasound, you should get on and get the appropriate imaging. These individuals should be fit enough for treatment, as we've previously discussed, and they should just be fed through. The incidental findings or the acute admissions with a liver lesion are more difficult. Here, they present under your care. The first question is, does this individual have cirrhosis or liver risk factors? And if they don't have any of those, and it doesn't look like a typical HCC, this obviously needs to be managed as a non-liver primary, and they need to be worked up as either an indeterminate lesion or seek out the primary and manage through the appropriate MDT or the upper GI MDT. If there is a question as to whether there's underlying liver disease, the question that really matters next is how bad is the liver, because that really dictates what we do next. And here we need to know whether they're compensated or decompensated. And if they're decompensated in any way, they need to be seen early as possible by a hepatologist or gastroenterologist with an interest to try and really get the liver disease as good as possible, assess for portal hypertension, get the appropriate imaging, and then refer through. So if you have any concerns at this point, I would recommend speaking to your local hepatology team to move the patient forward to the MDT, because it's only once we have all of that appropriate information that we can really make any kind of decision. We don't see all of these patients centrally. We're reliant on the information that's fed into us, and therefore our decision making is really limited if we don't have the appropriate assessment by the referring team. So how do we get on once we've got this patient through to the MDT and decide what we're going to do with them? So there are two things. The way that we stratify our patients for treatment is based on the Barcelona Clinic liver cancer staging and treatment pathway. And this splits up patients based on three factors. Firstly, the size and number of the tumours. Secondly, performance status, as you would expect. And finally, by liver function. And if they have poor liver function, so that's Child-Pugh C disease or advanced Child-Pugh B, then unfortunately there is no treatment option at that time apart from best supportive care. For these individuals, I would recommend looking to see whether there's option to recompensation to try and optimize liver disease, because we certainly have people who've decompensated for an infection, say, they're well managed, the liver improves as the treatment goes away, they have the appropriate nutrition, and they're brought back to the MDT after the initial discussion after 3 months or so with good liver function, and they can have potentially curative treatments or palliative treatments at that time. The other thing I would say about the Barcelona system is that it's been around for over 10 years now, and there are several new treatments that we have to fit in around the bottom. the exact place of some of these treatments is less well established than others. For example, it's quite well established now that rather than just transplant, you should ideally refer all these patients to Cardiff as a non-transplant centre at the same time as your transplant centre. And the reason for that is that we would be the ones who will be asked to give the holding or downstaging TACE. So we can get on to do that whilst the transplant team are completing their workup. What you really don't want is to refer somebody for an HCC and the tumour to move outside of criteria simply because they haven't been treated. Another new treatment is radiotherapy. Its position is less clear as to where it sits alongside ablation and chemoembolization, as I'll discuss later. CERT, which is transarterial radioactive beads, which are delivered directly to the tumour, is recently commissioned. Its position is not clear. And systemic therapy has predominantly been sorafenib, but now we have other multikinase inhibitors, and more excitingly, we now have immunotherapies which have been licensed for HCC. So when we look at curative treatments that are available, surgery, in about just over 10% of our patients in South Wales are surgical candidates. This actually has the best outcome, but there is a risk of decompensation, particularly around portal hypertension and liver function. Transplant has a 70% 5-year survival. It has very strict listing criteria when it comes to HCC. And this is really because if you remove the liver, but there are already seeded micrometastases, when you immunosuppress that individual, those micrometastases will unfortunately take hold and spread and often recur in the transplanted liver. And unfortunately, the person will have gone through a major operation with very limited benefit. In terms of ablative therapies, microwave ablation is well established. 15% of our patients in South Wales receive this. 5-year survival is 40%, and we treat lesions up to 3 or possibly 4 centimetres. SABR is a relatively new treatment in the UK. It's well established in North America. 5-year survival is about 20%. There are limited studies comparing it to a microwave ablation, and they're all either commissioning through evaluation or retrospective matched cohort analyses. And there is similar 1 and 2 year survival to microwave ablation. The criteria that I think we're working towards, although its place is still to be fully defined, is Child-Pugh A disease. Lesions that are less than 3 centimetres and not amenable to microwave ablation, and lesions that are greater than 3 centimetres that have failed TACE, or there is some other contraindication to TACE, which would mean that this would be the next choice. During the pandemic, I think the one positive thing that has come out regarding HCC is that the various pressures on different points of the system meant that actually Velindre was a good place to treat these patients. And so we put through more patients and probably adopted this more readily than you would otherwise expect a new treatment coming through or a new treatment modality coming through to an MDT. TACE is the main treatment modality that we deliver in South Wales. About 25% of patients receive this. It's a palliative procedure, a median survival of 20 months. However, there's a great range in survival dependent on tumour characteristics and size and the liver function. There's a relatively simple scoring system called HAP, which helps us to stratify these individuals. And what you see is actually relatively modest changes in the bilirubin and albumin have quite a significant impact on your survival when you're considering TACE. As mentioned previously, there is now CERT, which has been approved. Exactly how it will be delivered in Wales still has to be defined. There's experience from trials in Cardiff, and we are currently trying to sort out the commissioning and establishment of this service. Certainly the relative positions of CERT and SABR are really not clear which to prioritise, and this will need to be done as a nuanced discussion on a patient-by-patient basis. Systemic therapies make up about 10% of our patient cohort, and for the last 10 years or so, sorafenib has been the mainstay of treatment. It can be used in Child-Pugh-A and B7 disease, and adds about 10 to 13 months median survival benefit compared to 7 months with placebo in the registration study. It does have significant side effects of diarrhea and hand-foot eruption, which make it a difficult treatment for many patients. A major advance over the last year is the advent of immunotherapy, atezolizumab combined with Avastin, which has shown great promise. The median survival for the immunotherapy group is 19 months compared to 13 months in the sorafenib arm. However, as a caution for our patient cohort, the survival is far greater in those in the with viral hepatitis in the Far East compared to NASH patients. However, it's far better tolerated, as shown in the lower figure, than sorafenib, and for that reason, it is certainly being adopted. So what are we seeing in South Wales? So this is some work done by an SSC student. So he looked back at the 2 years before COVID and the year of COVID. We saw 340 patients, new referrals over this time, predominantly men, mean age was 70. Just coming up to a third of them had a performance status of 2 or less. The etiology was predominantly alcohol and NASH. We saw far lower levels of viral hepatitis, and I expect as we eradicate more and more hepatitis C and manage hepatitis B with well-tolerated oral medications, I hope that we'll see less of these sources of HCC in the future. When we look at the liver function of people referred to the MDT, what we see is whilst most are well compensated, about a quarter of our patients have Child-Pugh-B 8 and 9 or C disease, and therefore precluded from treatment based on their liver function alone. This is some data from prior to the pandemic, and what we saw when we looked at how long it took patients to come through is there's often a bit of a delay coming through from the point of suspicion to the MDT, and then a delay from the MDT through to the definitive treatment, as we would like by day 62. But one of the striking things here is that across our cohort prior to the pandemic, about 23% received a curative treatment and 37% went for best supportive care. So what we would ideally like to do is try and identify patients earlier, manage the liver disease better, and try and provide better treatments for these individuals in the future. One of the final things I'd just like to talk about is the impact of COVID that we've had on the MDT. There's a couple of quite busy figures here. The figure on the left shows 2 lines. In blue, first of all, you have the baseline of referrals to the MDT, and then you have these big swings in referrals to the MDT. In red, after the pandemic was declared, and in the dotted line you see the number of cases per month in Wales. And what you see is that the number of cases in Wales doesn't appear to have that much of an impact on the referrals. It's actually our lockdowns that are impacting on the referrals to the MDT. And during the COVID pandemic year, we saw the same number of patients with advanced disease who were only fit for best supportive care, but unfortunately we saw a reduction in numbers of those who were for curative intent treatments or TACE. So the final thing that is worth mentioning is that currently we're under significant pressure, as with many of the MDTs, with increasing incidence of disease, aging population and comorbidities. We're getting quite a lot of patients who we have to rediscuss as they come through multiple treatment lines. We have novel therapies and modalities that we still haven't quite got a grasp of their ideal place in the system. And this is all adding on to our pressure. Unfortunately, we are in a slightly unique situation with HCC, that we're not a fully funded service. So currently trying to build a case of support for the MDT. In particular, we need to have HCC specialist nurse support so that we have a better governance structure. And in the longer term, we need to have a full business case so that we can fund our IR services for what they are delivering fully. But I'm hopeful that we now are on the right track with this, and we should see an improvement in establishing these structural factors for the HCC MDT over the next couple of years. So I'd just like to finish by thanking all those who take part in the MDT. It's a very large team who help to support, I think, reflecting the fact that it's quite complex and we have lots of different treatment modalities that we need to consider. In particular, I'd like to thank Natasha, who has been a fantastic coordinator and really does respond to all of my queries straight away. She's gone above and beyond during the pandemic. And the final thing I'd like to say is that we currently have a fatty liver disease questionnaire which has been produced, which you can pick up here on your phone. And I'd be very grateful if you could just take a few minutes to fill that in. Thank you very much.
Thank you very much, Tom, for an excellent start to this morning's conference, and such an interesting topic as well. And I'd just like to extend my personal thanks to you for all your efforts that you've put in coordinating that MDT throughout the pandemic. So it's my pleasure now to introduce the next speaker this morning, who is Trish Duncan. Trish is a consultant hepatobiliary surgeon at the University Hospital of Wales in Cardiff. She graduated from St Andrews in Manchester, then went on to complete post-CCT fellowships in both Bristol and Cardiff. She has a significant interest in perioperative care, ERAS and rehabilitation, as well as cancer outcomes, and the modern management of severe pancreatitis. She is currently the surgical representative for the NELA group at UHW, involved in improving outcomes for patients having emergency laparotomies, and has recently been the local principal investigator in the ELF2 study. Trish is also a superb colleague of both myself and Andrew, and certainly contributes significantly to the HCC MDT. So it's delightful now to be able to introduce her to provide the next talk of this session. I'd just like to remind everyone, while Trish is loading her presentation, that if you do have questions or comments, please feel free to add them in the talk and chat box, and we will endeavour to answer as many of those as we can at the end of this session following Ben's talk.
Hi, can you hear me? It's just loading up. Very kind. Thanks for the introduction. That's super kind. So it's just preparing my slides, and I'll say hello. Hi. Can everybody see those?
Perfect.
Okay, I'll start. Let's see. So for those of you who don't know me, my name is Trish. I am one of the consultant liver surgeons at UHW, and thank you very much for the organisers for letting me actually speak. I will try very hard to make sure I take the time. Not great at pre-recording, I have to say. Just to introduce the rest of the team at UHW. So from the surgical side, for those of you that may or may not know us, Mr. Kumar, who has been here for a long time, and more recently myself, David O'Reilly, and our new colleague, Mr. Alessandri, who allowed me to take a picture of him. But just with the surgical team, we've got 2 CNSs, Shan and Bethan, 2 secretaries, Shan and Gina, and currently we've got an HPB trainee, Nick Mowbray, as well. And as you can tell, we've all recently been at Bethan's wedding. We're a tight-knit team. But that's not all the team, and it's just a quick thank you before I get into the meat of the presentation for the extended team. And we've got our HPB radiology team, our interventional radiologists, our colleagues that do ERCP and EUS, oncology. I haven't put our anaesthetic and perioperative care team who help us make sure we do the safest surgery possible. And as already referenced, the hepatology and gastro team, and the surgeons, not just locally at UHW, but beyond, like Di, Andy, and Fidan, that help us to really build a service that is not just here at Cardiff. So I've been asked to talk about colorectal liver metastases, so that's what I'm going to do. So just to say, I think we all deal with patients with bowel cancer. It still affects tens of thousands of people in the UK per year. And somewhere between 10 to 35% have synchronous metastases at the time of their presentation. And about 50% of patients will go on to develop liver metastases throughout the course of the disease. So, you know, what does surgery do? What do we, how do we affect these patients who have liver metastases? Do we do anything useful at all? Well, this is a slide from quite an old paper now from the 1990s, and this was just looking at patients with colorectal liver metastases, all comers, and it just looked at groups of patients that had no resection, non-surgical treatment, and resection, and are not resection, so what we'd call a clear pathological margin. And you can see that there's a difference. A third of patients surviving, and no patients surviving who didn't have resectable disease over the course of 5 years. So we do something, and we don't do it alone. This is a slide from the LiverMet survey, and the LiverMet survey has been going for, I think, nearly 20 years now, and it recruits patients from across the world, multiple countries, 63, and over 300 centres, so that we can all put our data in about liver surgery patients. So and you can see this is a slide with all comers. So these are patients with metachronous, synchronous disease. They may have extrahepatic disease, but you can see that survival up to 10 years is 25% in patients that have been resected, and that bottoms out at 2% for patients that have not had surgical treatment. So I'm happy to say that I feel that surgery does add something to the mix significantly. Okay, so what is resectable in 2021? Because this has really changed over the last 20 years. And actually, it's not dogmatic what's resectable. I think when liver surgery started out, there was quite a lot of criteria that we used. But actually, that game has changed. And now what we feel is resectable is the likelihood of achieving a complete resection of all evident disease with negative surgical margins, whilst we maintain an adequate liver reserve. And for most patients, you need about 30% of liver. So all the reasons that we used previously that would exclude patients from surgery, or we had concerns about offering them surgery, are not really a barrier anymore. Historically, start with number of liver metastases. So if you have a heavy burden of liver metastases, yes, your prognosis is worse. But when you look at the data, if you look at overall survival, the red lines are 1 to 3 mets, and the green lines are 10 mets or more. Yes, the overall survival drops, but it drops from 49% to 30%. So that's still 30% of patients that you have 5-year survival in. So that's a difference. I'm going to make a note about resection margins, which we're all very interested in when you're seeing these patients and trying to think about their prognosis long term. And there's different types of resection margins. So historically, an R0 resection for liver means that you need 1 millimeter clear. However, we've got something called a vascular R1 margin. And if for those of you who are not sure what that is, if there's a picture there on the slide, you can see that a tumor is sitting on one of the main veins, the middle hepatic vein of the liver. And what we do at surgery is we just peel that off that vein to preserve the vein, to preserve the outflow to that part of the liver. And when you look at this specific subset of R1s, you can see that an R0 resection has a 61% 5-year survival, but an R1 vascular is coming up very close with a 57% 5-year survival. So R1 vascular can also achieve local disease control almost equivalent to an R0 resection. So we shouldn't be ruling patients out even if they've got tricky tumors and we can't take that, that particular blood vessel or vein that's associated with it. So we don't rule those patients out. What if they get Mets coming back? Well, this is a super old slide, and it was actually it's from about 2001, 2002. And actually, when they looked at survival, this was a small study, but we have bigger data sets now to support this and better survival from redo resections. But if you look at the 1, 3, and 5-year survival for patients coming back for repeat resection, 1-year survival was 100%, 3-year survival was 46%, and 5-year survival was actually up at 32%, with a median of about 2.5 years. I think those results are actually better now looking at modern data. So having recurrent liver mets does not rule you out for surgery. And age. I had to put this paper up because obviously we've published on it, many centres have published on it, but this is looking at data from 2013 from here at UHW, 2013 to 2019. And elderly patients, actually, if you've got the right patients and the right disease, what we've demonstrated is that they have just as good 5-year outcomes, and we can get them through surgery safely. So age in itself is not a barrier. And one last thing, as Dime referenced it when he introduced me, what about patients that are not that fit or patients that are significantly deconditioned from chemotherapy or results of chemotherapy? Well, we can do more to get more patients through to surgery and to get them through their surgery better and recovered better, and that's prehabilitation. And I had to reference it because I have spent 3 years trying to help set up a prehab program with a team here, and we're just about to start that for patients having cancer surgery. And that's hopefully to optimize patients, get them through their surgery in better shape, back to their functional baseline after surgery quicker, and to maybe get more patients into surgery who perhaps we would be concerned about if they're not that fit. Okay, so what's changed? So all these things are not ruling patients out for surgery, and what's really changed the game over the last decade or so is the changes in chemotherapy. So you can see from 2000 up to heading towards 2015, the changes that have come both with standard chemotherapy and monoclonal antibody therapy, and the work that's been done looking at the genetics of bowel cancers. So this is chemotherapy alone increasing survival, and when you put that together with surgery, there is a significant survival benefit. So what we're looking at is when these patients are presenting, if you've got 80 to 90% in a non-resectable group, you want to put them into chemotherapy to see what number of patients you can move through into a resectable group, because this will improve survival. Okay, so once we've ruled all these things out, they're not too old, it doesn't matter that they've got lots of mets, we think we can give them a good margin or a vascular margin. What about the technical limits to our ability to resect tumours? What if the liver remnant that we're going to leave behind is too small? Well, we've got lots of games to play with to get more liver, because I'm not sure if you noticed my opening slide had lovely Prometheus on it, and the regenerative power of the liver is what makes it unique. So if we need more liver, these are just some techniques that we can use to try and get cancer out for patients. We can use portal vein embolization to try and get more liver volume. We can use a combination of surgery and ablation techniques if we can't remove the tumours fully. We can do 2-stage techniques, or we can do an ALPS procedure, which is a rapid 2-stage technique. So we really have a lot of things to play with, even if we can't take all the cancer out in one setting. And when you look at survival for these patients, you can see Again, this is data that I've taken from the liver met surgery, that even if you have to use resection plus ablation or two-stage resection and other techniques, these patients still have got good 5 and 10 year survival. So we want to get as many patients to surgery as possible. And as you see, there starts to be a shift once you put chemotherapy and expanding indications in. We get more and more patients to surgery, and that means that more and more of our patients will be alive at 5 or 10 years. The last thing I'm going to say about managing colorectal liver mets is that centralization and specialized centers do make a difference to patients, because if we are seen and treated in tertiary centres, you're more likely to be offered a liver resection than those in referring hospitals. And it really is a team effort, because if everybody in that room is invested in making sure as many patients get the right treatment or have the treatment that can possibly get them to surgery, more of these patients will survive. It is very important. And we do need to be a fixed team. Where the oncologist needs the surgeon to look at resectability, timing of the resection, to so that their chemotherapy achieves the goal of keeping the patient alive for longer and hopefully in reasonably good shape. And we need our oncologists to make these decisions and try and figure out the best strategy for them. It's really important. This is a paper from Liverpool. So this is looking at centres in the UK, and even in the UK, where HPB is a tertiary specialty, patients with liver-only disease, not all these patients have been referred to the MDT, and when these patients were reviewed retrospectively, about 63% of them were considered potentially resectable. So that's 20, 30 patients in that group in that small study that they looked at that could have been offered surgery and potentially could have had more treatment. So what do we need to do? We need to extend the indications, use conversion chemotherapy, first and second line, personalize the treatment according to molecular biology, and we've got specific technical techniques that we can use and expertise MDT management. So I've got a few more minutes, so I'm going to I've got little slides about how we do it and a case and just what's coming in the future. So I will move on. So for those of you that have never been to see a liver resection, this is what we do. We chop up bits of liver. That's a segment 5 monosegmentectomy. We've got special equipment that allows us to cut through the liver. And we do quite a lot of detailed preoperative planning to make sure that the liver we leave behind is well vascularized and in this case, remove all the cancer. And you can see with a good margin there, definitely more than 1 millimeter, which is ideal. This is the liver has been mobilized, and the little structure that you can see with all the titanium clips is the IVC heading up towards the diaphragm there. And this is a routine maneuver when we're operating on tumors on the right side of the liver or up behind near the cava. And I have a personal case presentation. This is a patient that was referred to me, who was a 60-year-old lady who was fit and well, who presented with PR bleeding with a CEA of nearly 2,000. And when she presented, she was staged with a primary sigmoid cancer of T3N0 M1 liver disease, and she had KRAS BRAF status. Looked like she was going to respond to EGFR therapy. So she was started on FOLFOX and went on to panitumumab. Always struggled to say that one. I'm just going to show you her presenting scans. So I'm sure all of us, if we were faced with this patient, would think that is terrible disease. You can see that the whole of her right liver and into her left liver is extensive cancerous disease with only sparing of the left lateral segment, if that, which is very small, but a heavy burden of disease. And obviously this is metastatic synchronous disease. So off she went to have her chemotherapy. And this was the response from the liver mets. And I've got actually I've got it on MRI as well. So she's still got, this is the pre and post chemo scans, pre-chemo on the left and post-chemo on the right. So she has this really incredible response to her chemo and her therapy. And so she's quite rightly referred back to the liver MDT. Now, the thing is the tumors have shrunk down, but she still needs an extensive resection. She still needs basically the whole right side and half the left side of her liver. And I've just drawn a little pink line there to show where the resection would be, and leaving only segments 2 and 3. So she went on to have a right-sided portal vein embolization. And then we re-imaged the liver. She still had very stable disease, and we're just starting to see the hypertrophy there. And she went on to have a right trisectionectomy. And this is her scan 6 months post-op. So that big chunk of liver you can see is just the segment 2-3 that I left behind, that it's just hypertrophy. It's doing what the liver does and functioning beautifully. And she's had her primary removed also, and is currently, as far as we know, cancer-free. So from that burden of disease you saw at the start, sometimes, you know, you really can get an amazing response. I've got a couple of minutes to just tell you about the future. We already do laparoscopic and minimally invasive surgery, and we're planning to try and increase that to take on the bigger, more challenging cases. This is a paper by my good friend Asmund, who works in Oslo, who's been one of the forefront surgeons in minimally invasive liver surgery around the world, and they've published the COMET study, and there's also the ORANGE study coming from the Dutch group, just showing that laparoscopic liver surgery is safe, and even major laparoscopic liver surgery is safe and gives equivalent outcomes, but is better for patients from the point of view of their terms of functional recovery and getting back to normal. As you can see, what the plan is for more minimally invasive surgery here at UHW, and robotics. The robots are coming, everybody. They're going to be an adjunct to our technical ability to do very, very aggressive surgery and minimize the risks to patients in combination with 3D mapping. AI is going to be very much a part of what we do because of the three-dimensional nature of our surgery. Virtual reality planning, which is already being looked at in studies around the world, which obviously looks very cool, but not been able to get my hands on it yet. And using ICG green as a method of tumor detection and protection of the biliary structures during surgery. We've got more adjuncts to getting more liver, double vein embolization, hepatic vein embolization, as well as portal vein embolization to try and maximize future liver remnants. And from the point of oncology, obviously new treatments coming through, but also hepatic artery infusion pumps. There's very few centres offering this around the world, and there's definitely an interest here at UHW. And we're looking at other modalities such as SBRT. So we are forward thinking about how we are going to get more or do more stuff for our cancer patients and try and improve survival for this group of patients in Wales. And just a note about liver transplant, the evidence is coming through that for certain, now that we understand more about the genetics of these cancers, that certain groups of patients may do well with liver transplant surgery. So I would not be surprised if in the next decade there will be a change of indication for which patients with metastatic bowel cancer could be considered for liver transplant. I've got one take-home message for everybody. Please refer if in any doubt at all. The more patients we get to resection, the more chance that the patient will have a survival benefit, will be alive in 5 or 10 years. We would like to keep pushing the boundaries and advocate for our patients, and we hope that you would do the same. And I think that's pretty much it. Thank you very much. That's my reason for wanting to be around for as long as possible. And those are my contacts if anyone wants to message me or anything that you would like to stop about. Thank you very much.
Thanks, Trish. That was an absolute masterclass. I thoroughly enjoyed that and learned a huge amount. I can see Di nodding as well, and some of the chat in our admin group has been saying the same thing. So that was a wonderful talk. So we're going to save some questions for the end of the session, if that's okay. So we're going to move on now to introduce our next speaker, and it's a great pleasure for me to introduce Dr. Ben Hudson, who is a consultant hepatologist at the Royal Devon and Exeter Hospital. Ben is the lead for the Basel Specialist Interest Group on End-of-Life Care, and his doctoral research thesis investigated healthcare needs and resource utilization among patients with decompensated cirrhosis, and looking at how principles of palliative care can be integrated into the management of people with advanced liver disease. So Ben is really dragging the UK forward, really, in terms of improving end-of-life care for people with liver disease. And it's a great pleasure to welcome back, albeit virtually, to Wales. I'm very much looking forward to hearing his talk.
Hi, my name is Ben Hudson. I'm a hepatologist in Exeter. Thank you to Wage for inviting me to talk today. Now, my objectives today are to provide an evidence-based argument why we should be integrating palliative care into the routine management of our patients with advanced chronic liver disease. I want to describe what palliative care is and importantly also what it isn't, and describe the barriers to palliative care in advanced liver disease, and finally talk through some strategies to how we actually achieve this and how we do it. So this is data from NHSBT showing that the number of transplants we do each year has modestly increased over the past decade, but that number pales in comparison to the number of deaths from liver disease. Now, no self-respecting hepatologists could ever do a presentation without this slide, but it does show quite starkly the increase is in deaths from liver disease over the past 40 years. In England alone last year, there were over 10,000 deaths from liver disease. So across the UK, there's probably 15 patients dying from liver disease for every one that receives a transplant. But even among your patients listed for liver transplantation, their prognosis is uncertain. Again, data from NHSBT recently showing that if you're listed for transplantation, the chance of you dying or being delisted over a 6-month period is around 10%. And all of these patients, whether they're listed for transplantation or are not appropriate for transplantation, will all experience the features of advanced chronic liver disease. And I'm going to talk through a little bit about what that involves. So liver disease is associated with an incredibly high burden of physical and psychological symptoms. This systematic review from Peng et al. That was recently published in Palliative Medicine looked at over 80 studies which compared symptom prevalence in a range of very common life-limiting diseases. And it highlighted the particularly high symptom prevalence of patients with liver disease, both physical and psychological. It also highlighted the nature of these symptoms as being often blind spots for us as hepatologists. Falls, breathlessness, depression, pain, things that we may not routinely address in our routine practice. And this perhaps feeds into the wider determinants of quality of life. And another excellent recently published systematic review highlighting that patients with liver disease have demonstrably poorer quality of life, health-related quality of life, when compared to other life-limiting conditions. And the determinants of that poor quality of life, again, may be blind spots for us as hepatologists. Frailty and the sequelae of frailty, falls, poor sleep, malnutrition, things that we may not routinely address in our day-to-day clinical practice. End-stage liver disease is also incredibly expensive for healthcare systems. And given the poor quality of life that's associated with it, there is a question about the value of care that we're currently providing. This was a retrospective database study from Ontario that looked at healthcare costs across a range of conditions in the last year of life. And it highlighted not only that liver disease had the highest overall healthcare costs, but that cost escalated hugely within the last 90 days of life. And if you drill down into the reasons for that, the reasons were readmissions, long hospital stays, and the frequent use of ITU interventions during a terminal admission. This points were backed up in our British study looking at deaths of patients with refractory ascites between 2013 and 2015 in England, showing that the vast majority of deaths were occurring following an unplanned kind of crash landing emergency admission. The readmission rate within the last year of life was over 50%, which is huge, higher than almost any other condition. And a large proportion of patients' last year of life was being spent in a hospital bed. All of these factors have been separately and independently associated with poor quality of life. Now, these retrospective mortality studies, I get that they're not perfect. There will be a proportion of patients in both of these studies in whom intensive care and the terminal admission was the right decision, that recurrent readmissions were the right decision. And of course, these studies don't see the patients who survive. However, given that this these factors are so strongly associated with poor end-of-life care, and there is such a high rate of readmission. It does raise the question about whether better models of anticipatory care and anticipatory care planning could improve quality of life for a high proportion of our patients. Because currently, patients with liver disease do not experience a good death and they don't get good end-of-life care. The biannual Voices study picks this up repeatedly. Deaths from liver disease are consistently rated as poorer by bereaved carers and relatives than in other life-limiting conditions. Joe Lowe's group in the Royal Free looked at some of the reasons for this and looked at some of the needs, end-of-life needs in patients with chronic liver disease. It looked at, it was a systematic review that had a total sample size of over 2,000. And it highlighted the problem of patients having a very limited understanding about what their condition was, what the likely trajectory was, and what the possible outcomes were. And it also highlighted the problem with clinicians often feeling untrained, unsupported, and not able to have these conversations properly and in a timely fashion. This was highlighted in a smaller qualitative study which we did in Bristol among patients with refractory ascites and carers that had been bereaved by liver disease. And although a much smaller study came out with very similar conclusions, I've highlighted one quote here of a patient bereaved by liver disease. We knew he had to come into hospital every so often to have the water drained, but as far as what that meant, that they ultimately couldn't do anything about it, well, that information was delayed a lot longer than we anticipated. It would be better if people were told from the start. And if I could signpost you to just one paper from this talk, it would be Victoria Guy's account of her sister's death from alcohol-related liver disease, which she wrote back in 2006. And it shows the consequence of not doing this well and quite how harrowing a death from liver disease can be. I've highlighted one quote, but the whole article is definitely worth a read. The last 5 months of Lisa's life were not lived in quality. She could not turn herself in bed, feed herself, get herself a drink, or go to the bathroom by herself. And her mental capacity varied between completely lucid and completely disorientated. We were all frightened. Was it my responsibility to ask for palliative care and insist on adequate pain relief? So hopefully I've demonstrated that this is important because the syndrome of advanced chronic liver disease has a very high physical symptom burden. There's a demonstrably poorer quality of life than other life-limiting diseases, has huge healthcare utilizations, and is associated with a very poor quality of end-of-life care in most, but not all cases. So I wanted to talk now about what palliative care was, also what it isn't, and look at the evidence for how this can improve quality of life in patients with advanced disease. So I'm going to start with just going through the WHO definition of palliative care, which refers to it as an approach which improves the quality of life of patients facing the problems associated with life-threatening illnesses through prevention and relief of suffering by means of early identification, assessment and treatment of physical and psychological symptoms and other problems. What palliative care is not is end-of-life care. End-of-life care forms a part of it, absolutely, but it is not synonymous, and it's important that those two things are seen as different. And palliative care is also not specialist palliative care, and should really be a core skill of all physicians managing life-limiting diseases, certainly including hepatologists. In terms of the evidence for the use of palliative care in patients with advanced diseases, I'm going to go through some of the evidence around this. This is another retrospective database study from Canada, a population-based study which showed the beneficial effects of palliative care on healthcare systems, admissions to both intensive care, hospital and death at home, and showed the favourable impact of palliative care interventions on those outcomes. And it's interesting that those outcomes were most accentuated in patients with end-stage liver disease or cirrhosis. And this was a similar thing was demonstrated through a different mechanism through a prospective RCT that was recently published in the USA. This was Ricky Sinner's group, which looked at patients admitted to hospital with a complication of chronic liver disease, in whom their clinician would not be surprised if they were to die over the next 12 months, something that's referred to as the gold standard question. It looked at the impact of a very simple palliative care intervention, which was just an inpatient consultation and goals of care discussion and a follow-up conversation with a nurse specialist following discharge. And he used as his primary outcome measure time out of hospital and length between next readmission. And he showed a significant increase in the time to readmission in the intervention group. It showed a significantly higher proportion of time out of hospital in the intervention group. But importantly, there was no difference in mortality between the two groups. So this idea that curative and palliative care are mutually exclusive and you do one when you've exhausted the other is one that needs to be quashed. Palliative care is not end-of-life care. And this point is emphasised in this nice study from the US, which looked at the impact of a palliative care intervention at the point of liver transplant assessment. So most of the patients in this study went on to be successfully transplanted, but it looked at the impact of palliative care interventions and focused on symptoms, both physical and psychological. And 3 months down the line, among the patients that weren't transplanted, there was an increase in quality of life. There was a reduction in CSD scores, which was a marker of depression, and an improvement in all markers of most markers of the common physical symptoms associated with liver disease. So despite the good evidence for its use and despite hopefully demonstrating the need for it, palliative care is still seldom used in advanced liver disease. I've highlighted 3 single center studies from the US, Canada, and the UK that all show that palliative care is introduced as an afterthought and seldom, if at all. Although there is, as the study I've highlighted on the right does show that rates of palliative care referral in the US and Canada for cirrhosis are starting to increase, and there is an increased attention on this area. So it's worth thinking about why that is, why patients with liver disease don't receive palliative care. And it's often because there are some quite specific barriers to it in our patient group and with our disease trajectory that we manage. This was a pretty comprehensive US study of physicians managing advanced liver disease across a range of specialties by Necker Ufir's group in the US. And she highlighted key areas which made palliative care in liver disease difficult. She highlighted that there was a very uncertain trajectory in liver disease, and clinicians felt uncomfortable introducing the concept of palliative care when there was still the possibility of cure, abstinence, transplantation, whatever. There was a common misperception, as I've mentioned before, of palliative care being synonymous with end-of-life care, and clinicians felt inadequately trained and equipped to undertake discussions around uncertain prognosis, and that made communication around goals of care very difficult because clinicians felt ill-equipped to do it. Also, they felt they didn't have time to do it, and that the systems and structures of care that they had just weren't set up for this patient group. So I'm going to do the last half of the talk looking at how to do palliative care in liver disease. And I think I've highlighted the goals of palliative care, which are that patients understand what their disease is and they understand its prognosis, that they have an opportunity to be involved in decisions around their care, that their symptoms are well controlled and their quality of life is optimized, and that their loved ones are supported in managing them. I've highlighted the barriers, which are the difficult and uncertain disease trajectory, the common misperceptions of palliative care, not only amongst patients, but also amongst physicians, the difficulty in communicating prognosis and prognostic uncertainty, and the absence of clinical models which reliably can integrate both curative and palliative care. And I think this comes down to 5 factors. It means you need to have patients which are identified routinely and in a timely fashion. You need to have strategies for communication of prognosis and advanced care planning. You need to have skills and expertise in managing difficult symptom control issues and optimizing quality of life. structures for carer support, and a service which meets the needs of our patients and changes to the design of that service. Going through each of those in turn, there's been a bit of work done around how we signpost patients in a timely fashion for palliative care. And there's two screening tools which I've highlighted. One is a Scottish design tool, the SPICT, which signposts clinicians to palliative care based pretty much on features of the decompensating illness. And I've highlighted the screening tool we developed in Bristol, which looked at the presence of 3 out of 5 criteria to highlight patients for palliative care, those being Charles-Pugh C disease, readmissions, ongoing alcohol use, being unsuitable for transplantation, and a poor performance status. Both have been validated and have held up pretty well. However, it's a lot more tick boxes in a junior doctor's busy day. So there are arguments against these tools as well. But it does mean if you have some strategy for routinely identifying patients, patients aren't missed, and the opportunity to introduce meaningful palliative care interventions isn't lost. So introducing a routine screening tool is certainly something to be considered. The second issue that was highlighted particularly as a barrier in Dr. Ufear's study was that clinicians often struggled with communicating an uncertain trajectory and an uncertain prognosis. And what I've highlighted here is a tool that was developed in the American surgical literature around the idea that patients find risk a little bit difficult to understand when it's explained to them via a statistical model, and find visual analogues much better. So the thing that they've developed is something called best case, worst case, most likely. And you could use it for interventions or describing an uncertain prognosis. The example I've used here is a patient admitted with frailty who's admitted, discussing admission to an ICU for management of variceal bleeding and encephalopathy, where you describe the best case scenario as an ITU stay, a prolonged hospital stay, rehabilitation and some return to function, the worst case scenario as death on the ICU. And then you physically put on this chart to the patient what you think the most likely thing is and whether it's closer to the best case or the worst case scenario. And it's something I use a lot, and it's facilitated these discussions really nicely, something I'd really recommend. And another group in America looked at prospectively at the impact of using this kind of tool. So they had called it a goals of care discussion, and they looked at the impact of introducing it prospectively, 3 months without the tool and 3 months with the tool, which was just a goals of care discussion at the point of admission. And what did they find? Well, they found that there was an earlier introduction of DNAR orders in the intervention group. There was an increased time between putting a DNAR order in death, meaning there was a longer time for the family and loved ones to understand the gravity of the situation. There was a reduction in the length of ITU stay, an increased time off ITU, and a reduction in the number of deaths on ITU. And there was an increase in the time between organ support being withdrawn and death. Again, improving end-of-life care in the last days of life. But the most important thing that reassures skeptics to this is there's no difference in mortality between the two groups. In fact, the mortality was slightly better in the intervention group. Again, quashing this idea that palliative care and curative care have to work in a mutually exclusive fashion. They really don't. Obviously refers to a kind of ACLF, very sick population. There's also outpatient strategies. This is a really nice bit of work, again, from Joe Lowe's group in the Royal Free, that just looks at a question prompt tool that's sent to patients before their outpatient visit, giving them, if you know, the bit at the end, have you got any questions? Here are some things you might like to ask, and giving them 1 or 2 to choose from per consultation so that the clinician's not overwhelmed. And interestingly, although it wasn't done with this intention to demonstrate it, by far the most commonly asked questions by patients in the outpatient setting was, what is my life expectancy? What can I expect? So although we might think our patients are nervous about this, certainly a good proportion of them, actually it's really important for them to have those conversations. The next issue I'm going to talk about is symptom control, and a lot of you will have seen the REDUCE study, which was a feasibility RCT comparing the use of long-term abdominal drains in patients with refractory ascites to repeated and recurrent large volume paracentesis. It showed that the long-term drain group understandably had a reduction in their overall albumin levels, but that this wasn't associated with reduction in renal function. Most of the complications weren't that difference between the two groups, although there was an increased rates of blockage and self-limiting cellulitis in the long-term drain group. There was a much lower procedure burden, which meant patients could be managed in their own home and the community much more. Interestingly, this didn't relate to improved quality of life in the LTAD group, which is actually slightly worse than the paracentesis group. So there's still some very important unanswered questions around LTADs in refractory ascites. And we've currently got an HTA grant in. We'll hopefully fund a national study to do a fully powered RCT in this now. I really hope that that's successful. I was delighted to see that palliative care is now making it into guidelines. This is highlighted in the most recent BSG guidelines on the management of refractory ascites. But of course, ascites is only one feature that impacts on symptom control and quality of life. I haven't got time to talk about pharmacological management of symptoms in end-stage liver disease, but I would signpost you to the Basel SIG website that has a nice, succinct guideline that can be incorporated into hospital policies and is freely available. Symptoms aren't the only determinant of quality of life, as those previous studies I've highlighted have shown. And one of the features that's coming out increasingly in the liver transplant literature is the impact of frailty, both its inability to predict prognosis much more successfully than traditional scores like MELD, interestingly, but also to improve quality of life. And Felicity Williams' study that I've highlighted on the right looked at the impact of an exercise program on patients on a liver transplant waiting list and showed improved self-care, improved quality of life, reduced pain, and improved physical function. And those interventions are likely to be just as beneficial in a patient group that aren't suitable for transplantation. A similar study looking at falls from Elliot Tapper's group in the US has recently shown very similar findings, that interventions which proactively address frailty, improve prognosis, improve quality of life, reduce symptom burden. So having structures to do that is important. Carer support is a really difficult area, something we don't do well, an area of huge unmet need. Again, I've highlighted some literature that's available on the SIG website, but certainly something we need to develop. And finally, I want to talk about a service that is fit for your patient's needs. So this was a study from my MD, which again, another qualitative study, which looked at the needs of patients approaching the end of life and contrasted them to the hospital services that were provided for them, and demonstrated this huge disconnect by what patients needed in this phase of illness and what the hospital-centric model of care traditionally provided. And one approach that's being used is the use of advanced liver disease, MDTs. I'm going to quickly talk you through what we do in Exeter, although there's models popping up all over the country. So in Exeter, we have a monthly meeting where we discuss patients with new decompensating illnesses, or HCCs. The most important people in those meetings are the physios, the OT, and the dietitians who have specialist design time for liver patients, and we triage patients that we get the most benefit to those groups. So there's two streams generally, prehabilitation group and an end-of-life group, and they have a hugely beneficial impact. But there's also palliative care physicians there. There's representative from community hospice. Our alcohol nurse also attends. And as well as triaging patients to the most appropriate specialty, we also complete a treatment escalation plan for each of them in the case of a deterioration, which is subsequently discussed with the patient so that they have input into it, and it's made available on the hospital system so it's accessible by staff out of hours. A system in Worthing has shown really improved end-of-life outcomes with a similar model. And I think an advanced liver disease MDT is a really good place to start. So to summarize, advanced liver disease is deeply unpleasant. It's got a very high symptom burden associated with a poor quality of life and is hugely expensive to healthcare systems. Palliative care can improve these things, and I think palliative care should be a core component of services which manage patients with advanced liver disease. And that should involve identifying patients with a poor prognosis, good communication about their disease, actively addressing physical symptoms and frailty, supporting carers, and where possible, enabling advanced care planning. We've got our Basel SIG meeting on the 21st of October. Please join us. I'm really keen for it to get as many people interested in this as possible. Thank you again very much for inviting me. It's a pleasure to speak.
Thank you, Ben, for a superb talk there, and just like to echo Andy's thanks for taking the time to speak to us today. And certainly your work has really inspired, I know, the guys in the Gwent Liver unit and ourselves in Cwmtaf to really take palliative care seriously. And certainly the tools that you've designed have certainly helped us locally to develop those conversations with patients and palliative care physicians as well. So just like to thank you for that, and to obviously Tom and Trish for two excellent talks before. So we'll move on to a question and answer session now. So if you have got questions from the audience, please continue to add them into the chat box. And certainly one that popped up during your talk, but I think something that should be asked again for the audience really is something that from our Vice President John Green regarding metastases, and he asked Trish, can you explain why isolated or small volume liver metastases are not resected at the time of the initial colorectal operation? And John says, from a non-surgeon, please go easy on me.
I was gonna say, go easy on me with the question. Don't ask me anything hard. So it's a slightly complex issue. We do, the short answer to John was we do occasionally in the right, when we think it's the right cases. If you look at the systematic reviews of synchronous resections with bowel cancer and liver mets at the same time, if you read those, if you read the summaries, they'll say, oh, you know, less time in hospital overall, same sort of complication profile, probably same mortality rate, possibly slightly higher in the synchronous group, etc. So you sort of think, oh, sounds like a great idea. So there's a couple of things. There's a lot of very skewed bias in the cases that are chosen for synchronous resection. For example, if you're doing a low anterior resection and you've got a tumour right at the back of the liver on the IVC, you're actually operating on diametrically opposite ends of the body. And for liver surgery, for those of you that know a little bit about it, we run these patients extremely dry, hypovolemic. So we want a low central venous pressure for them to minimize the risk of bleeding during surgery. Whereas if you're doing an anastomosis, you want it to have normotensive good blood, you want to try and maintain physiology. And so sometimes we need big fluid shifts around liver surgery. So those cases that are being selected for synchronous disease, there will be a lot of bias in that selection so that the outcomes are quite good. I think the problem for our local, and speaking very honestly about local team, is we do need to increase the amount of minimally invasive liver surgery that we do. And I think as we take on, the more challenging minimally invasive cases, then there will be more scope. But patient safety has got to come at the forefront. And we know that if you're having something like an anterior resection and a major hepatectomy, then your risk of mortality and morbidity is actually higher. So I think patient safety at the front, synchronous cases when possible, and I think you will see a slight increase in that. I hope that's helpful.
Very great. Thank you for that, Trish. Really comprehensive answer. So, John, you had a question for Ben. Do you want to come and ask the question directly?
Yeah, I do. Hi, Ben. Are you there?
John, really good to see you again.
Oh, you're there. Hello, you're in the ether. I can hear you but not see you. Hiya, Ben. Really enjoyed the talk.
Thank you.
Good to see you and welcome home to Wales. Strikes me that we all sort of need to normalise conversations about death and dying in our practice, and I think we can all be accused of perhaps not being as proactive as we should be with those conversations. I think we're probably quite scared to have those conversations, particularly in people with so-called benign disease, which is probably not the right expression with somebody with end-stage liver failure, but those sort of patients. I wonder whether you could give us, I really did enjoy what you presented, and it's quite sort of made me think a lot actually about some of the patients that we deal with outside of the end stage metastatic malignancies. I wonder if you could distill your talk down for all of us to come up with two things. One, how should we routinely include those conversations about death and dying in our practice, in the patients that we see in clinics or see on the wards? And how do we actually develop the skills to do it well? Because I think we probably feel more confident in doing somebody who we know has got, metastatic malignancy and has got a very limited prognosis. But I wonder how we can bring some of those conversations in earlier with somebody who has clearly got a life-limiting so-called benign condition.
Yeah, I mean, really good question. It's hard when the trajectory is uncertain. And the reason that patients with metastatic malignancy who have been through an MDT, who have said there's no curative therapy for this, get better palliative care, is because it's an easier conversation to have when the trajectory is certain. And often in liver disease, you don't know which way it's going to go. You've got factors particularly relating to abstinence, but also relating to, there's transplantability, and there's often a lot of uncertainty. So I think your first question was how you introduce it in benign disease. And I think a good start is always asking a patient about where they are, where their understanding of their disease is, and what their understanding of the next year is, and getting an idea of how much they want to know. And then I think I found the best case, worst case, most likely structure a good way to move away from it. It can be very difficult to have a conversation that includes the words palliative care early on, because there's a misunderstanding of that terminology amongst patients and clinicians. So I think in terms of describing it in terms of what you're aiming for, what the best case is, but also what can sometimes happen, and talk about how they prepare for that. So it's not seen as it feels like that people worry about losing hope. But certainly trying to do those in advance of the kind of crash landing admission can make things much easier down the line. In terms of how you develop the skills for that, I think that is difficult. I think it is something that's a blind spot within high specialty training for gastroenterology and hepatology. When we were in Bristol, when I was in Bristol, we had a quarterly communication skills session with our palliative care physicians, and they joined us in a monthly advanced liver disease clinic, and helped us out with that. I think but I think a lot of it is about having conversations which are iterative and developing relationships, and it not being a kind of one point where you offload all the information in one go, which can be quite overwhelming, particularly in an inpatient setting. So there are kind of strategies to improve it. I think changing our high specialty curricula would be useful. And I think the challenge is explaining uncertainty. Explaining a definitely poor trajectory is much easier. And that's the challenge with it.
So I'll just come in on that as well, Ben, if that's okay, because I think you're being overly modest, okay? And I think that's because I think we've introduced your checklist in Gwent for a number of years. We base our inpatient MGT, which is weekly, around that checklist. And it's transformed the way we approach liver disease care. So to answer John's first part of the question, the checklist is brilliant at just focusing your mind on that highest risk group that you need to start having the conversation, maybe even on that first admission. So even if they look ostensibly okay, you're identifying a cohort of patients that are much more likely to deteriorate, need critical care, whether that's appropriate or not. So we have got much better at having those proactive discussions as a consequence of using that checklist as part of a weekly inpatient MDT. And then we've got better at doing that because we just do it more and we refer more to palliative care, and then palliative care are more engaged with us, so it becomes a virtuous circle. So I think I would advocate anybody looking after liver disease patients, get Ben's checklist. It's on the paper. It's easy to apply, and use that as a template to start to think about how you have your end of life discussions and your escalation discussions, and it's transformed what we do. So I think Ben's been overly modest there, which is typical of him anyway.
That's very good of you, Andy. I suppose one of the advantages of it is you can say when there's uncertainty and it doesn't feel like a real thing at that time, which often doesn't for people when they don't have cancer. That in a year's time, when we looked at people that were in your group and we put your numbers into a calculator, if you use that tool, for example, if you had 100 people with this severity of liver disease, about 20 of them would be alive in a year's time. So although we'd really like you to be in that 20, we also need to make a kind of parallel plan for how we improve your life if things don't go to the best case scenario. So it does take away a little bit of that kind of putting your finger in the air, saying, I don't like the look of this kid, type of subjectivity to it, I suppose.
And can I just add one thing, Ben? I just wonder, it's something that we have to think as it's beyond gastroenterology and hepatology, about how we educate the medical profession about the prognosis of some of these conditions, like end-stage cardiac disease, respiratory disease, liver disease is actually worse than the majority of malignancies. And how do we get that sort of message across? I think it must be through training and education from a young age. And also, I think the thing which I find difficult having that conversation would be, you've explained that beautifully, actually. I find it much easier when I've got somebody who's got a scan with metastases and malignancy, and the patient almost expects that to happen. But it's a difficult conversation for me and the patient when they've got something which is, has that uncertainty and doesn't have the big C involved in the sort of the diagnosis. So I think it's just something we have to bear in mind. And I have had conversations with patients who've got clearly end stage medical things, and try to explain to them and find a way of explaining to them that the outlook over the next year is that equivalent to somebody who had widespread it's that sort of thing we've got to try and get across to ourselves as a profession, but also out there as well, because I think a lot of people feel they can live forever with non-malignant conditions. I think we have to sort of find a way of getting that through. So yeah, thanks very much, Ben. That's brilliant.
Yeah, thanks, John.
Yeah, thanks, John. I'd echo that as well. I think the challenge with cirrhotic patients, certainly in South Wales, is they're often young as well. And we're dealing with people younger than ourselves, and telling them that they've only got 6 to 12 months to live is often very challenging, and the families don't accept that as well. But sorry to bombard you, Ben. I've got another question for you. You mentioned long-term drains, and it's certainly something that we are talking about and using a bit more now in our health board. And I think there's two questions really. The first is, how do you come to that decision? And I know there's no hard and fast rule and tool of this, and I suppose we think about long-term drains in those who perhaps would be suitable for TIPS, who perhaps don't qualify or are not well enough for a TIPS. So firstly, how do you identify the patient who are likely to benefit potentially from a drain? And secondly, a technical question, do you routinely use antibiotics in all patients who have a long-term drain to try and prevent secondary infection? I know most of these would probably qualify for prophylaxis based on their albumin and protein anyway, but do you routinely use it as a prophylaxis or just wait until they get an infection?
Brilliant question. I'll tell you what I do, but I'll caveat it with the fact that there is not good evidence on long-term abdominal drains. And this is an unanswered question. We've got an NIHR grant application in at the moment, which has caused me all sorts of sleepless nights. And I'm really hoping it's funded, which will look at the wider determinants of this. So we don't know the answer, and this is a work in progress. But for what it's worth, I'll tell you what I do. I think it benefits patients who are not right at the very end of life. So I think your life expectancy probably needs to be guesstimated. That's all we can really do. It's around at least 2 to 3 months. I think you probably need to have a drain frequency of more than 2 a month, because they're not without problems. I don't think we have sufficient evidence to recommend them in patients who would be a candidate for TIPS or transplantation. So I wouldn't put them in that group. And I would also be slightly anxious about putting it in a group with alcohol-related cirrhosis or alcohol-related hepatitis due to the propensity to recompensate and the particular risk of septic decompensations in that cohort. I think the group that they're great for is NASH, who are outside an age or with a comorbidity profile, which is going to make transplant non-feasible. In terms of what we do with them, prophylactic antibiotics, yes. On the basis of what you've just said, they're likely to benefit, we don't know. But also in the limited data we got from the REDUCE study, there's a rate of self-limiting cellulitis. It's likely to reduce peritonitis rate, likely, but we don't know, we don't have the evidence. And what you're trying to achieve is reducing readmissions. So your goal of that is to reduce readmissions. And although the antibiotics don't come without risks, in the long-term trajectory, I think the benefits of prophylactic antibiotics outweigh the risks. So yes, all patients get antibiotics. In terms of how we do them, we bring them in on a Thursday. We drain them to dryness at the time of the initial drain with albumin replacement for that index drain. And then we use the kind of easel basis of not draining more than 5 litres a week over 3 occasions. So we say the community teams go in and drain up to 5 litres a week without albumin replacement. If they're requiring more than 5 litres a week, we admit them to the day case unit to do a full paracentesis through that drain, so they don't need a repeat procedure, and with albumin cover. But for most patients, that 3 times a week drain in the community is sufficient. I think we have the important thing in the REDUCE data was that the quality of life in the long-term drain as quantitatively measured was worse than in the repeated paracentesis group. So we haven't got this is not set as the best thing to do. From my experience, patients who are engaged, have NASH cirrhosis and have a little bit more social support, and who aren't going to be transplant or TIPS candidates are the ones that do best with this. And those, from my experience, anecdotally, are the ones for whom this is of most benefit.
Thanks, Ben. That's both reassuring and helped me finalise my SOP as well. So that's a brilliant answer there.
I've got a question for Trish, if that's okay.
Yeah.
I think we've clearly shown that the liver surgical service has grown enormously, certainly since I've been in post. And the indications are extending all the time. I was pleased to see that 11% of the HCC workload is going to surgery, because that's probably higher than some other parts of the country. Do you think we have the requisite capacity to continue on with these extended indications and do the things that we know we want to deliver for our patients?
I thought I said no tricky questions. I'm sure all of us that work together with HCC and part of the bigger HPB community around South Wales know that we are at a stretch. But do we need to do it? 100%. I think we need to, as a team, and certainly from the surgical side, we do need to build that capacity if we do not want to be, it's not good for patients from around Southwest Wales to be shipped outside of Wales for treatment. Those centres, they're far from home, far from family, hard from all the support systems. And although we have to do it occasionally, that's not what we should be building here. I strongly believe that that's what we should be building the capacity in and future-proofing it so that we can do better for our patients all round. We want to be able to offer a more dynamic service. We want you to have rapid access to these things, but we have to integrate it in Southwest Wales. It's not an easy ask, as you know.
Yeah, thanks. I mean, I think it might be a good opportunity to bring Tom in here as well, in terms of, and I don't know if Mohd Khan is in on the meeting this morning, but, Mo's been very successful in getting additional resource for the neuroendocrine service, which has really gone from strength to strength. Is how do we harness perhaps the patient voice or other sort of stakeholders to try and raise this issue, because we do desperately need more capacity within not just the HCC, but probably the liver surgical side, the interventional radiology. We could probably do more portal vein embos. We could push the boundaries more and more. So I suppose it's a broad question to Tom, is how he thinks we can try and influence our commissioners really to sort of deliver the service that we want to be able to provide for our patients.
Thanks, Andy. So I think that's a really interesting question. It's something I've thought quite a lot about, and where the best place to draw the line on this is, because there is fundamentally a problem when you're talking about cancers such as liver cancer. So many, and I often think of it in comparison to breast cancer, which is the field which my wife works in. you have a cancer here where you have a far more marginalized group. Clearly, there's increased risk factors with increasing socioeconomic deprivation. The cancer incidence to mortality ratio for HCC is one of the highest of any cancer. And depending on the study you read, it's higher than pancreatic cancer. So these patients are dying more frequently, more early of their disease. So it's not like breast cancer, say, where you have your treatment and then you have a long period on, say, hormonal therapy in which you have that time and ability to campaign on behalf of your particular interest group as a patient. So it's a difficult ask to mobilize. I have personally not gone down that route because I think that there are benefits and I think there are risks that you run with this. And I think that this is, unfortunately, what we actually have is we have what should be a very clear moral imperative. Why the flipping heck do we not have one tumour site which doesn't have a proper MDT? It is completely unacceptable for the Welsh Cancer Network to carry on with 150 patients referred to an MDT without a CNS. And unfortunately, the traction that we gain, as you well know, and I know how hard you've tried to work for this, it's just simply very difficult to get what is a tumour site outside of the interest of a lot of our oncologists to move up the agenda. I think we are doing it, but we're doing it unfortunately because we're now getting to a crunch point where we have an MDT which is just about functioning. I'm afraid that we now have a 3-week wait quite often from referring to our MDT to actually discussing a case. This is unacceptable, but there is no other way that we have the capacity to get through the cases. And I think now we've got to a point that we are, it's accepted that this has to be done. And I hope that it will come through. But I find it difficult to, and I'm reluctant to put it onto a group of patients to say this is for you to push for. I think that actually we as clinicians should clearly be able to get our own house in order on this. I don't know how you feel. You're all, the three of you I'm seeing on the screen, we have these conversations regularly. So I think you already have your opinions.
Well, go on, Andy, you go first.
I was just going to say, I was trying to see if you had an easy solution, because I certainly don't have one. I think, we are starting to work with the British Liver Trust, who are quite good at raising the voice. We've got a Senedd event coming up now. And Tom, you're involved in some of those discussions as well. So, we can perhaps, we got a cross-parliamentary group on liver disease now. It's being set up in the Senedd, and we can try and perhaps leverage some of our, members of the Senedd to try and raise this as an issue in sort of question times, during parliamentary question times. And I think probably each of us in our own localities need to continue to bang the drum and engage with our members of the Senedd and people of influence to keep raising the questions, because, as you say, it's on the face of it, it's a no-brainer. It should happen. And why is it the only tumour site that doesn't have a dedicated MDT seems ludicrous? Because the volume is increasing, as you say. Sorry.
No, I just echo that, Andy. And I think, as Thomas said, I think we've got a duty as clinicians to really advocate for our patients. I think a lot of our patients, certainly the alcohol-related cirrhotics, are often judged and perhaps not seen. This isn't seen as a no cancer is sexy, but it's not a popular cancer. I think that it's not had the recognition it deserves. And I think we're also a victim of our own success, perhaps, Tom, now, in that all the health boards are really buying into that MDT. We've got representation from almost every health board and site. And as a result, we're now sending more people to you. And as a result, our waiting times are going up. So I think it's for us all really to work as a team, which I know we do. And hopefully perhaps Wage can offer some political voice as well in the months to come to really raise this on each and every occasion we have an opportunity to do.
So I've seen some other questions pop up. So Ben's got a question for you, Tom. Ben, do you want to ask the question direct, or do you want me to?
No, I was just interested in the
we're finding our way as well with CERT and SABRE, and I was wondering how you thought the landscape was changing for the indeterminate stage HCC as per the Barcelona stage, and which patients you think are doing well with SABRE as opposed to moving on to the systemic therapies, which seem to be better tolerated in the post-sorafenib era. I'm struggling to get a feel as to whether we're kind of over-tasting patients with the Atevo Bev now in the armamentarium, and didn't know what your thoughts were on that.
So I think that this is really an interesting and difficult place. And this is one of the reasons actually why we struggle, because we can't increase the numbers we just discussed, because the discussions are really difficult because we don't have an evidence base to lean on. So the first thing to say really about SABRE is we're very lucky, and I think actually in South Wales we probably have greater experience of SBRT than a lot of MDTs across the country, and that's because we've got 3 local clinical oncologists who have done fellowships in Canada who are able to provide this service. So we have a proper SABRE MDT, and we're leaning on quite a lot of existing experience. The way I think that I view SABRE, and again, we've now done 13 patients because of COVID, and the fact that actually Velindre as our cancer centre has been much better for us to be able to feed patients through there than come to percutaneous ablation. So, but I think that it is something that I would consider as an ablative therapy in the first instance. I think that we probably use it where other centres may be talking more about intraoperative ablation. This is a good alternative to that. Where it sits with TACE, we still very much are on the line that TACE should be, if you have a taceable lesion, then that is the established treatment, I think. And we would use TACE followed by SABRE. I think that the question, I think, is really with the systemic therapies is that we need to see, actually. I think that there's going to be a real question and I think the evidence is definitely gathering that actually for our NASH patients, and we're talking about alcohol and NASH, really, very little viral hepatitis driving our HCC. And I think in this group, you're not getting a better outcome with immunotherapy necessarily than TACE. I think that if you were in the Far East and you had the choice between TACE and immunotherapy, there's large numbers of patients who would probably be far better off not having immunotherapy, but that nuance still hasn't come through. So I think that is really where we sit at. And the issue with all of this is that there are no good studies. And if you have a HCC, which is good for treatment by TACE, so it's a small lesion that's got a very good vascular bed and well arterialized, those lesions will probably do far better with interventions such as SABRE, which again, will obviously do better with smaller lesions. But you need to have, and this is something I didn't fully appreciate until quite recently, is you need to have quite good oxygenation, I understand, of the tumour for the radiotherapy to work well. So good tumours will respond. And so teasing this out is going to be really difficult. And to get good studies is going to be really hard. And there aren't any on the horizon, really.
Are there any patients you're using concomitant systemic therapy and TACE, or are you getting to the end of local regional therapies and then introducing systemic therapies? Yes,
so that's certainly how we tend to be doing it. I don't think that there is, we haven't gone for both. We occasionally look at lesions and say, oh, that one looks really good. That's a tasty one for the IR boys to get onto. And then there's some lymph nodes that we can think about a bit later on, but we're not doing it in combination. And again, I'm not aware that there's good evidence that particularly helps. But these are the things that and we are increasingly flexible. In the case I presented, we used Sabre and TACE, and we are doing things like using different lines concurrently in different sites. And I think that is the kind of approach that we'll be using more, rather than immunotherapy for everybody plus on top.
And I think, Tom, the issue we've always had is that we'd often TACE to patients with very multifocal disease, because we knew sorafenib was very marginally effective with a high side effect profile. And I think we will see a shift when we will be pushing those patients much more to combination therapy rather than TACE for those ones that don't have a nice discrete lesion that will respond well to embolization. So I think we've started to see that sort of move, and that's a discussion, haven't we?
Yes, and I think that the HAP score is very helpful for this, because you can select out the patients who are likely to have more issues. But unfortunately, the trouble with things like HAP is that, if your AFP is 2000 and your tumor is 11 centimeters and you can't resect it, unfortunately, you've got quite large disease, which is going to be challenging to treat with whatever modality you choose.
Good. We wanted to bring Lawrence in. Lawrence, you raised an issue. Do you want to sort of raise a point or a question, Lawrence? Lawrence and Daraj? No.
I'm not sure if he's got access, Andy, but certainly.
Oh, fine. So Lawrence has posted a couple of things that people can see them. He says Wage should support HCC and represent to WAG RE this issue. The Liver Plan Group should push HCC. We have been working on that, and Tom's been very helpful with that as well. We continue along those lines. A bit of a plug now, so the LFT pathway, the All Wales liver blood test pathway, will be launched this Friday, so that's tomorrow. If people do want to register, go to the ICST website. A quick plug for that. We've got 197 people registered for that event. There's a lot of interest in that. We hope that will increase the rate of cirrhosis detection, which will potentially identify patients at an earlier time point, so we can survey and pick up more cancers at earlier time points, so we can give Trish even more work to do. And I think, yes, absolutely right. Lawrence goes on to say we should think about priorities RE-HCC when we discuss with Senate members. So I think, yeah, I think a vote of confidence for Lawrence in that sort of approach. Are there any other questions from attendees? No,
don't think there are. So if there aren't any more questions, I'd just like to thank all three speakers this morning, Tom, Trish and Ben, for some superb talks and some very fruitful discussions afterwards. Also like to thank Andy for co-chairing this session, and for Wage for giving us the opportunity to do that. So all that's left for me to do now is to thank all our sponsors who've sponsored the events. You can see most of the names in reverse behind me and in the proper way behind Andy. So there's now a coffee break where the sponsors will have some pre-recorded videos for you to hopefully spend some time watching and engage with. And then we'll be starting back at 11:30 for our keynote speech before lunch. So thank you very much. Diolch yn fawr i chi gyd.